So thank you very much.
So hi, I'm Helen Pearson. I'm an associate professor in the Department of Anatomy at Temple Med School. If any of you went there, you may have had the unfortunate experience of me teaching you gross anatomy as well as neuroanatomy. So you're here despite that. So a little bit of self-deprecating humor. Spinal cord anatomy. This is just going to be a very straightforward review of the structure of the spinal cord, some of the basic gross structures of the spinal cord. I'm hoping that for many of you, this will be really a review more than anything that's going to introduce a whole lot of new material for you. So in the beginning, I'm just going to start out by reviewing the spinal cord structure as well as some of the regional characteristics. So this is a summary diagram showing the, did I get the pointer or should I just, do I just use the, okay. So looking at a cross section, the axial cut through the spinal cord, I'm sure that you remember the butterfly shaped region. I'm sure you see this on a regular basis looking at imaging. The gray matter with the surrounding white matter. So the white matter can be described in terms of three major regions: the posterior funiculus, which is located between the posterior or dorsal median sulcus, and the location of the dorsal horn and the posterolateral tract. So then laterally is the lateral funiculus, and anteriorly or ventrally is the anterior funiculus. Anatomically, the gray matter can be divided into the rexed laminae that are indicated by the Roman numerals. Do you use that? Do any of you have? Sometimes when you read publications about the anything to do with the spinal cord gray matter, then there will be references to the rexed laminae. So they are described somewhat more of laminae in the dorsal horn, more as clusters of cells in the ventral horn. So, so when we're thinking about the white matter, we're dealing with not only the neuronal axons, but the glial cells. Most of the axons in the spinal cord are myelinated. The funiculi that I just mentioned, posterior, lateral, anterior, contain multiple tracts. There's the funiculus is just a general region of white matter. And then within those regions, there are the individual tracts or fasciculi. The posterior funiculus consists of the posterior white columns, the dorsal columns, whatever term you are used to using for those, which are made up of the, bless you, gracile and cuneate tracts, which also can be referred to as the fasciculus gracilis, fasciculus cuneatus, depending on how Latinized you like to use your terms. Other key tracts, the lateral corticospinal, the anterolateral system, which is made up of several individual tracts, but principally is containing the spinal reticulars and the spinothalamics, the anterior white commissure of the spinal cord, and the posterior posterolateral tract, which is also known as the tract of Lissau. And then other major descending tracts, the reticulospinals and vestibulospinals, and then the ascending tracts to the cerebellum, the spinocerebellus. So this is showing then a histologic section through the spinal cord, just showing the different cell types that are located within the gray matter. You can see the correlation of the, again, the rexed laminae if you're particularly interested in that. So looking at the ventral horn, the location of the motor neurons within the ventral horn, these tend to be organized somatotopically. So the limb, the drawing of the limb here, that represents the axial muscles going out to the proximal limb to progressively more distal muscles in the limb. The lower motor neurons that innervate these muscles are organized somatotopically, with the lower motor neurons innervating the axial muscles tending to be located more medially, most medially in the ventral horn, and then progressively as you move laterally in the ventral horn, you're passing through lower motor neurons which innervate proximal limb muscles, and then most laterally are the muscles or the lower motor neurons that innervate the muscles of the most distal limb. There's also some topographic organization based on whether the lower motor neurons are innervating flexor muscles versus extensors. So the different regions of the spinal cord, from the cervical, the thoracic, the lumbar, the sacral, have distinct characteristics in terms of the shape of the spinal cord and the relative proportion of gray matter versus white matter. So at cervical levels, you can kind of recognize those levels because the spinal cord tends to be rather oval. There's also quite a large amount of gray matter. There's one dorsal column. There's just the, there's two dorsal columns within that posterior funiculus. So there's both a fasciculus gracilis and a fasciculus cuneatus within the cervical levels. There's a reasonable amount of gray matter in the ventral horn, particularly at the lower cervical levels where the lower motor neurons are located that will supply the axons going into the brachial plexus. So the cervical enlargement. At thoracic levels, the gray matter is rather skinny. The horns are rather skinny. Again, there's a reasonable amount of white matter. At the upper thoracic levels, there are the two dorsal columns in the posterior funiculus, both gracilis and cuneatus. At lower thoracic levels, there's just the single gracilis. At lumbar levels, there's a large amount of gray matter relative to a smaller amount of white matter. So the white matter has now, many of the descending pathways have left the spinal cord. The spinal cord hasn't acquired large numbers of sensory axons, ascending axons. So the white matter is relatively small compared to the gray matter. And of course, there's the enlargement of the ventral horn with the motor neurons of going into the lumbosacral plexus. And then at sacral levels, again, large amount of gray matter and very little white matter by this point. Bless you. Blood supply to the spinal cord. So the major supply, we have the anterior spinal artery, which is indicated here, going into this median sulcus on the anterior surface of the cord. There's, There is a single anterior spinal, and there's a pair of posterior spinals either side of the posterior median sulcus. And so the generally the both the posterior and the anterior spinal arteries are derived from the vertebral arteries, although there can be some variation in this. Sometimes the posterior spinal can be derived from pica. Right there. In addition, there are branches that are coming from segmental arteries. A lot of the posterior intercostals or the segmental arteries coming from the descending aorta in the abdomen will give rise to these medullary branches, which then give off radicular branches to the dorsal root or to the ventral root. The branching from the anterior spinal, you can see that it gives this nice branching into the bulk of the gray matter here, this central region. And on this image, you can see the filling of that anterior spinal artery, and this is the territory which is largely supplied by that anterior spinal. The posterior spinal supplies the dorsal columns, and then branches of both the posterior spinal and the anterior spinal supply branches to the outer surface of the spinal cord. And so there's this region called the arterial vasa corona, which is supplied by both vessels. Excuse me, I'm baking here. Spinal reflexes. So the dorsal root ganglion cells that are coming into the spinal cord can synapse directly onto a motor neuron in the ventral horn, or they can synapse via a motor neuron, via interneuron, sorry. So the main reflexes that occur at spinal levels, there are the stretch reflexes, there's a flexor reflex or a flexor withdrawal reflex, and then there are cross-extensor reflexes. So the muscle stretch reflexes are based in the sense organs within the muscle, either the muscle spindle or the Golgi tendon organ. So the myotactic reflex, I guess I have some circuitry diagrams here, which make it a little easier to explain. So the first one, the basic muscle stretch reflex. So this is the basis of when you're testing a deep tendon reflex. This is the pathway that you're testing the integrity of when you do that tendon tap. So you can see the little hammer here, tapping on the patella tendon. This stretch on the muscle will activate the muscle spindle, and the afferent arising from that muscle spindle is then going to terminate within the spinal cord gray matter, among other things. There'll certainly be ascending pathways signaling the stretch on the muscle, the change in muscle length. So these axon collaterals that terminate in the gray matter of the spinal cord, there can be a monosynaptic connection to a ventral horn motor neuron, which innervates the same muscle. So the tendon tap then produces contraction in the muscle, counteracting the muscle stretch. And there's the basis of your knee jerk response in this case. This is based on activation. This is of course, this is an alpha motor neuron. The excitatory neurotransmitter released within the spinal cord is excitatory glutamate, and acetylcholine, of course, is released at the neuromuscular junction. So the muscle contracts. At the same time that this reflex is initiated by the direct connection, by this monosynaptic connection on the motor ventral horn cell, there's reciprocal inhibition of the antagonistic muscle. So of course, if the system is producing a contraction of the quadriceps muscle, an extension of the knee, then it's not going to be very helpful if the knee flexors are activated at the same time. So at the same time these collaterals are producing the monosynaptic reflex contraction of the quadriceps, then the principally hamstrings here are going to be inhibited. And this happens through a kind of a signal inverting interneuron. This is an inhibitory interneuron. So the afferent from the muscle spindle will activate this inhibitory interneuron, which then silences activity in the ventral horn cell to the antagonistic muscles. So those antagonistic muscles remain in a relaxed state, and the they're not opposing the activity of the quadriceps. So the autogenic inhibition is another way that the spinal reflexes can operate. This is through the activity or the action in the Golgi tendon organ. So this is when a muscle contracts, it's putting strain on the tendon, and it activates the Golgi tendon organ. So that's monitoring contraction in the muscle. So this is an inhibition of the same muscle which initiates the reflex. So the Golgi tendon organ afferent signals, travels into the gray matter, into the ventral horn, synapses again on an inhibitory interneuron, which then is going to silence the activity in the lower motor neuron to the same muscle. So the muscles, this limits the contraction of the muscle. The withdrawal reflex is usually a response to pain. It's usually a response to a noxious stimulus. So a classic example is where you step on a tack or a piece of broken glass, and the nociceptor activated in the foot will send a signal into the ventral horn. So this involves a activation of the, this is the excitatory pathway here, where you want to activate the flexors to pull away from the noxious stimulus. So there's activation here. The signal is transmitted through an excitatory interneuron to the ventral horn cell innervating the flexors, and there's inhibition of the motor neurons to the extensors. So this produces withdrawal away from this dangerous object. At the same time, usually, certainly if you have this flexor reflex in the lower extremity, then although you're certainly concerned with pulling away from the painful stimulus, you're also somewhat concerned with staying upright. So when the flexor withdrawal response is in the lower extremity, this also will initiate what is known as the crossed extensor reflex in order to maintain support for the body. While you're pulling away with one limb, you want to be able to keep yourself upright with the other. So this is on the side where the broken glass is part of the illustration. You can see that the pain fibers here carrying the information into the spinal cord. This is the piece that we saw in the previous slide, where you're activating the flexors, inhibiting the extensors. There's also transmission of this information across the midline through interneurons, excitatory interneurons, which cross the midline and then interact with interneurons on the opposite side. So contralaterally, there's the opposite effect. You now want to activate the extensors in order to maintain your upright posture and inhibit the flexors on the contralateral limb. So contralateral extensor muscles are activated to support the body. Any questions so far? Is this pretty basic for you? So this will then, I'm just going to review now the tracts which make up the white matter that we saw in the different funiculi. So so we have a variety of descending pathways, ascending pathways, and some autonomic systems that are present within this area. So so beginning with the dorsal funiculus, also known as the posterior columns or the dorsal columns or the posterior white columns, these are made up of the gracile and cuneate tracts. The main characteristic of these different white matter pathways is that they're very heavily myelinated. They're transmitting, they're made up of ascending primary sensory fibers. So these are the central processes of the dorsal root ganglion cells that are carrying information such as the discriminative touch, vibration sense, pressure sense, and proprioception. Did I say that already? So this pathway is ipsilateral at this point. Pathway hasn't crossed the midline. These are central processes of the afferents coming in from the same side of the body. So the gracile tract, or fasciculus gracilis, is contains the fibers that are derived from levels approximately below T6. And the topography of that organization is that the fibers are coming in at each segment. They are kind of arranging lateral to the ones that already exist. So the most sacral segments or dermatomes are represented most medially, and then each one more laterally as you get to up to about T7. And then the fibers, for reasons that I don't understand, I don't know if there is an explanation for why a second tract is created, but essentially about T6, the fibers then start to create the fasciculus cuneatus. Both of these tracts project up to the medulla, with the gracile tract terminating. The axons terminate synapse on neurons of the gracile nucleus, and cuneatus terminates in the cuneate nucleus. So if there's a spinal cord injury to the dorsal white columns, there's going to be symptoms present on the same side as the lesion and loss of the discriminative touch, proprioception, etc. In the lateral funiculus, there are both ascending and descending pathways. So we have the major descending tract, the lateral corticospinal tract, present within that lateral funiculus here. So this is the pathway which is important for fine motor control, for fine fractionated movements of the distal extremities. The posterior spinocerebellar tracts, these are the tracts which carry what is sometimes referred to as unconscious proprioception, which is a term that kind of can be a little bit annoying if you are a stickler for the meaning of proprioception. Proprioception is defined as the conscious awareness of muscle length and tension and joint position. So by definition, you can't have unconscious proprioception, but it's easier to say unconscious proprioception than unconscious information of muscle length, tension, and joint position. So this is information which is transmitted to the cerebellum. And of course is critical information for the cerebellar function, allowing the cerebellum to match and correct, to match intended movement with actual movement and to correct motor error. So the major, besides these proprioceptive pathways to the cerebellum, the other major sensory system here is the anterolateral system. Many of you may use the term spinothalamics. Is that something you're more familiar with? Anterolateral system is more inclusive because many of the fibers in this tract, and I believe it's the majority of the fibers in the anterolateral system in the anterolateral tract, are actually spinal reticulars. So there's different populations of axons within this anterolateral tract or anterolateral system within the spinal cord. But regardless, the functions of these axons are carrying the pain, itch, temperature, and crude touch or light touch. The descending systems here, there are important descending autonomic fibers which are regulating the activity of the preganglionic, sympathetic and parasympathetic neurons located in the different regions of the spinal cord. Sympathetics, T1 to L2, and then the parasympathetics in the sacral segments 2 through 4. So the anterolateral system then, the system really begins with the dorsal root ganglion cells entering the spinal cord and synapsing on dorsal horn cells. The axons then cross to the contralateral side of the cord in the anterior white commissure. So the axons are located right in here in this little white matter tract between the central gray and that central median sulcus. So after they cross the midline, the axons come to lie in this region of the spinal cord, hence its name. They ascend to the brainstem, and then as they ascend the brainstem, they will give off axons to different targets. So within the medulla and the pons, there are the terminations of different spino-reticular axons. So as the anterolateral system is ascending, there's branches leaving that tract to terminate on reticular neurons. Once the tract gets to the midbrain, there's spinomesencephalic axons, which exit the anterolateral system, and they're going to terminate in different regions of the midbrain. And then finally, there's the spinohypothalamic tracts. So finally, except for the spinothalamics. So the spinoreticulus, spinomesencephalic, spinohypothalamic, so the other axons in the anterolateral system besides the spinothalamics. And there's also fibers in, we really think about the spinothalamics as the ones that ascend to the ventral, to VPL, the ventral posterior lateral nucleus of the thalamus, but there are also pain fibers that arise in the that ascend in the anterolateral system and will terminate on other thalamic nuclei. So the because of the crossing of this pathway, it's the second order neuron of the pathway still that is crossing the midline, that the injury in the spinal cord, if the anterior white commissure is injured, then there is, well, if it's the anterior commissure, then there's a bilateral loss of pain and temperature. If it's the anterolateral system that is lost, then it is damaged, then it is the losses of pain and temperature, etc., on the contralateral side, usually 1 or 2 levels below the lesion. So the spinothalamic tracts, these are the ones that kind of border the edge of the spinal cord of the white matter here, the anterior one and the posterior tract going to the cerebellum. The pathways will, for the 2 different pathways, there are synapses, particularly for the posterior tract, which is ascending from the lower limb. There's a synapse in Clark's nucleus, which is also known as nucleus dorsalis, which is a column of cells which extends from about a T1 to L2. And then there is the anterior spinothalamic tract is in the pathway is involving spinal border cells. The descending pathway, the lateral corticospinal tract, this is the main descending tract. It arises from different parts of the motor cortex. There's even components that arise from the primary somatosensory cortex that descend in this tract. And this is the primary pathway from the premotor and primary motor cortex. particularly involved, of course, in regulating the voluntary movements. And these axons will then terminate on the ventral horn cells, particularly in the lateral part of the ventral horn. If you think about the topography of that ventral horn, where the distal limbs are innervated by lower motor neurons in the lateral horn, then the descending pathways to those motor neurons are coming mainly in the lateral corticospinal tract. So injury to the descending pathway is going to produce loss of the fine fractionated movements of the distal limbs, particularly, of course, the fingers. It's also producing an increase in reflexes. Essentially, upper motor neuron damage is producing hyporeflexia, increased reflexes, and also increased muscle tone. Though I don't have that on this slide. And as I mentioned, lateral funiculus also contains the descending autonomics regulating. These are the upper motor neuron. This is the upper motor neuron pathway that regulates the activity of the preganglionic neurons. These are axons descending from the hypothalamus. Then there are a variety of motor pathways in the anterior funiculus. There's the different pathways within the medial longitudinal fasciculus. These are usually tracts that don't extend the full length of the spinal cord, and they're more involved in regulating, usually in orienting movements of the head, and such as the medial vestibulospinals and the tectospinals. There's also the medial reticulospinals, as well as the anterior corticospinals, which are descending within this anterior funiculus. So these are pathways. Here, these two regions of the spinal cord are highlighted. They're part of the pathways for the anterolateral system. The posterolateral tract contains the axons which ascend, has collaterals which are ascending as they enter into that region of the spinal cord, and the anterior white commissure is where they're crossing to the other side. That's all I have there. So pain modulation. So if you think about the ascending pathways from the dorsal horn cells that are carrying pain information that projects for conscious awareness of pain through the VPL of the thalamus and up to primary somatosensory cortex and beyond, then this ascending system is going to, activation of that ascending system will activate the descending pain modulation systems, which reduce pain perception. So generally, there are a couple of different ways of modulating the pain information, modulating pain perception. So the C fiber, this is just showing a typical C fiber afferent bringing information in. This is the central process of the dorsal root ganglion cell. And this will typically activate the projection neuron, the dorsal horn cell, which will carry information via the anterolateral system, via the spinothalamics in the anterolateral system, and activate pain awareness as well as other things. So the basis of the system, the TENS treatment for pain modulation, the basis of this is that the stimulation through that system will activate the non-nociceptive mechanoreceptors. It's also the basis of rubbing your whichever, if you crack your elbow or you crack your shin, it's kind of like, ooh, you know, that kind of rubbing it better. You activate the mechanoreceptors. It works better than giving somebody a cookie or whatever other kind of ways we try to help, particularly our children when they injure themselves. hugs work too, but this is, this is the basis of that, rubbing it or using the TENS system. So the activation of the mechanoreceptors actually inhibits the ascending pain information. So you can see how the C fiber is activating the projection neuron, and then when the mechanoreceptors are activated, and remember that these are kind of moderately myelinated axon, the mechanoreceptors, they have a higher conduction velocity than the pain fibers do. So when these A alphas or A beta axons are activated, they also come in and terminate on, I keep losing this pointer, sorry. They terminate on the projection neurons as well as on inhibitory interneurons. So they, you can see that there's an interaction here where the pain fiber itself inhibits the inhibitory interneuron and then activates the projection neuron, whereas the mechanoreceptor activates the inhibitory interneuron and decreases, which then inhibits the projection cell and decreases the transmission of information centrally. So this can reduce the activation of the pain pathways. This is a schematic which shows, this is just showing the blue, red, and green axons. These are the cell bodies in the dorsal horn cell. This is the ascending pathway. And you can see how axons terminate in the medulla. So this is just a schematic of the brainstem. This is midbrain here. The bulge is the pons. Here's the medulla. And this is a very truncated representation of the different levels of the spinal cord. So the cells, you can see here, the afferents coming in, dorsal horn cells, the projection neurons crossing the anterior white commissure and coming to form that anterolateral tract. The activation then, you can see these are spino-reticular axons within the anterolateral system. Here is the spinomesencephalics, and all of these are going to activate the ascending systems. So the descending systems, there are neurons in the various places, like the periaqueductal gray, and there are also centers within the reticular formation. There's nucleus raphe, dorsalis, and magnus. And these nuclei, the neurons then will project down. So there's a raphe spinal projection, which goes down to the dorsal horn. So activation of the ascending pain signal then activates the descending pain modulation system, which I think is just basically, this is what I said here, the ascending systems activate everything from the thalamus, including the somatosensory regions of cortex, and the cortex, as well as different regions, such as the hypothalamus, certainly the periaqueductal gray. This whole system will activate these different levels of the pain modulation system, which then projects down to the dorsal horn. And this is a schematic which is similar to what we saw with the mechanoreceptor activation. This is the descending pathways, such as from the raphe nuclei. And these terminate on an inhibitory interneuron or local circuit neuron. There is release of endogenous opiates, such as enkephalin here, and inhibition. In this case, it's showing a presynaptic inhibition of the nociceptive input. So the C fiber is inhibited from activating the dorsal horn cell. Any questions so far? All right, so I'm just going to review a couple of cases and how these relate to spinal cord anatomy and the pathways. I'm sure that you'll be very familiar with these types of cases. So in the first case, this is a case of ALS. We have a 40-year-old patient. She had trouble doing fine motor skills. She couldn't button her shirt. She began to feel she was very clumsy, dropping items. And this had been going on for several months. She had weakness in all the tests of motor strength in both of her hands, as well as apparent atrophy of all the intrinsic muscles of the hands. Fasciculations could be seen in the intrinsic muscles. The deep tendon reflexes in testing the biceps, I don't know whether that's, I don't know which biceps that is, the way it's written. As an anatomist, I'm very particular about specifying which one. Maybe it's femoris with the other lower extremity, or maybe it's the representation of the upper limb. Anyway, there were hyperactive deep tendon reflexes. So in order to interpret these signs and symptoms, the atrophy within the intrinsic muscles of the hand, the clumsiness, the inability to maintain the grip, as well as the fasciculations in muscles of the upper extremity would indicate particularly the atrophy and the fasciculations were very indicative of lower motor neuron damage. So there's irritation and death of the anterior horn cells innervating those muscles. So the hyperreflexia, the increased muscle tone, are signs of upper motor neuron involvement. As the atrophy is evidently spreading to muscles of the head and neck, the neck, tongue, pharynx, and larynx, as well as to the trunk, but usually sparing the functions of the sphincters. So this is showing an increased progression of the disease, particularly as far as the head and neck is concerned, a progressive bulbar palsy, the cranial nerve nuclei are involved, containing those other lower motor neurons besides the ones in the ventral horn. So, so this is what I understand to be a classic presentation of ALS, where there's a combination of both upper and lower motor neuron signs. I'm sure you know much more about this than I do. Yes, sound familiar?
Anatomically, why are the sphincters spared?
I don't actually know that. I don't know. It just seems to be, I don't know any specific reason why certain muscles are affected and others, why the lower motor neurons are affected and others aren't, or why the upper motor neuron control may be spared for as well. I think it's more the voluntary that are specifically being referred to here. But I think the pattern, you can tell me this, the pattern of ALS in any given patient is going to be different, is it not? The particular muscles affected, the particular upper motor neurons. So I don't know the answer to that. I'm not very good with why. I say that to the medical students when they ask me about the anatomy. Well, why? So my answer is always, I don't know, I wasn't on the design team. I know it's early, I'm trying to get you to smile a little bit. Okay, Brown-Séquard syndrome. So this is basically a hemisection of the spinal cord, which is often used, can sometimes be regarded as a purely academic exercise, but there are instances where essentially a hemisection of the cord occurs. This is the case of a young woman complaining of pain in the left breast area. and progressive weakness of the left lower limb that had been going on for a period of several months. Weakness in the left lower limb associated with spasticity, increased tone, and hyperreflexia at the knee and ankle. So on the left side, loss of two-point discrimination, vibration proprioception below the hip, and on the right side, a loss of pain and temperature below T7. The imaging showed an extramedullary tumor expanding from dorsal roots at the spinal cord levels of T5 and T6 that were expanding into the cord itself and compressing the cord. So the ipsilateral paralysis that is occurring below the level of the damage to the cord, this is an upper motor neuron injury. The spasticity, the increased tone, increased reflexes. So this is produced by damage to the lateral corticospinal tract. Ipsilateral loss of discriminative touch at the level of and below the level of damage. This is destruction of the posterior columns. And then contralateral loss of pain, 1 to 3 levels below the site of the lesion. Is involvement of the anterolateral system. And there's dermatomal pain. Pain in the left breast is from pressure on the that ipsilateral dorsal root. I think there's, okay, so this is just showing that very kind of, if this when this does occur, a classic pattern of that dissociated sensory loss where there's loss of pain and temperature in one limb, which is contralateral to the lesion, and then loss of ipsilateral proprioception and discriminative touch, ipsilateral to the level of the lesion. And then upper motor neuron weakness in this particular case because of damage to the lateral corticospinal tract. And this actually is a case of a young woman who suffered a stab wound to the neck. You can see it was a fairly small diameter knife or object. And this is the image showing the path of the knife through the neck. And here's the image showing the damage to the spinal cord. And it ended up being essentially producing a hemisection of the cord. And then finally, a little bit about syringomyelia. This is a 30-year-old man noticing weakness in his right hand, which was progressively worsening. He had bilateral weakness, atrophy, and fasciculations of intrinsic muscles of the hands and shoulders. Upper motor neuron signs evident in the lower extremities on both sides, and then bilateral loss of pain and temperature in dermatomes C2 to T6. Bilateral impairment of position and vibration sense below the hips. So the MRI shows a central cavitation of the spinal cord expanding symmetrically in all directions from levels C2 to T7. Of course, whenever you see bilateral loss of pain and temperature at specific dermatomal levels, it's usually an indication of damage to the anterior white commissure. And in this case, there's also the syrinx is expanding to include portions of the posterior white columns, the lateral funiculus, as well as the anterior horn. And this is an example of a spinal cord sectioned to show a syrinx cyst within the cord. You can see the central canal and how it is. Now, I think that most syrinxes, most of those are not, some of them, or maybe it's most, maybe it's some, are not necessarily continuous with the central canal. But you can see how, depending on the level of the spinal cord, that the syrinx can expand significantly to erode into both gray matter and white matter. So the patient had lower motor neuron signs indicating the ventral horn cells are involved. Loss of pain and temperature bilaterally is the anterior commissure involvement. Upper motor neuron signs of hyperreflexia, and in addition to the vibratory sensory loss of the dorsal columns. And that's a quick review of the spinal cord.